first of all, I was instructed by Dr. Reem to cut my talk into half, which is extremely difficult for a very, very gigantic topic such as this. My original lecture had something like 165 slides, but I've managed to cut it down quite well. And she instructed me specifically to stay less than 12 minutes. Happened. You can't deny it. Okay, so what do we mean by the cardiometabolic syndrome? The cardiometabolic syndrome is an interesting constellation of maladaptive cardiovascular, renal, prothrombotic, and inflammatory abnormalities. This is now recognized as a specific disease entity by many bodies. These cardiovascular and metabolic derangements include individually and interdependently lead to a substantial increase in cardiovascular disease, morbidity, mortality, making the cardiometabolic syndrome an established and strong risk factor for premature and severe cardiovascular disease and stroke. The best studied endocrine disease in correlation with cardiometabolic syndrome is diabetes. This is being discussed everywhere, and as it is extensively covered elsewhere, I shall not cover it today. Cardiovascular abnormalities associated with pathologic changes of endocrine glands are due to the fact that various hormones interact with the cardiovascular system. Pituitary, adrenal, parathyroid, and thyroid hormone excesses or deficiencies may produce cardiovascular disorders that usually resolve with the correction of the underlying endocrine disease. We'll start from upstairs with the pituitary gland. Growth hormone hypersecretion leads to acromegaly, which is associated with an increase in mortality due to cardiovascular disease. Risk depends on age, disease severity and duration, hypertension, insulin resistance, diabetes, and hyperlipidemia. They all occur frequently in patients with acromegaly. Additionally, we have right and left ventricular hypertrophy, aortic and mitral valve disease, which may persist despite cure. Secondary hypertension occurs in 20 to 40% of patients with acromegaly, and it is an independent factor for mortality in these patients. ECG abnormalities include left axis deviation, septal Q waves, ST, wave depression, abnormal QT, dispersion and conduction defects. All of these occur in and around 50% of patients. Moreover, atrial and ventricular ectopy, sick sinus syndrome, supraventricular and ventricular beats may occur. Transsphenoidal surgery with the resection of a pituitary adenoma is the procedure of choice. If growth hormone levels remain elevated, long-acting somatostatin analogs, growth hormone receptor antagonists, or radiotherapy can be used. Both hypertension and left ventricular hypertrophy improve with treatment within 6 to 12 months. Survival is significantly greater in patients achieving disease remission. Next, we go to hypopituitarism. There is a marked increase in cardiovascular mortality that has been observed in hypopituitarism patients who are growth hormone deficient. Although the exact mechanisms have not been delineated, meticulous substitution of glucocorticoids, sex steroids, and growth hormone is the suggested approach in these patients. I shall discuss Cushing disease with the adrenal. Parathyroids. The parathyroids can produce cardiovascular disease through either changes of the parathyroid hormone levels or through changes in serum calcium. Serum calcium regulates the synthesis and secretion of parathyroid hormone through a feedback mechanism. Hyperparathyroidism, usually primary, it produces hypercalcemia. The cardiovascular effects of hypercalcemia include an increase in myocardial contractility. The ECG findings are short QT, PR, blunting of the T waves, ST wave changes, which may mimic ischemia. Hypercalcemia provokes calcium deposits in the heart, the myocardium, the valve cusps, annuli, and conduction system. Although systolic function is normal, diastolic function can be disturbed. The treatment is the surgical removal of the parathyroid adenoma. Hypoparathyroidism. Primary hypoparathyroidism is exceedingly rare. but it can be seen after the surgical removal of the parathyroid glands or in the polyglandular failure syndrome. Low serum calcium prolongs QT and impairs cardiac contractility. Next to the thyroid, with hyperthyroidism, we have very predominant cardiovascular symptoms in the clinical presentation. With the patients come in with palpitations, increased heart rate, dyspnea, exercise intolerance. A subset of patients can experience an angina like chest pain or true myocardial ischemia, even with normal coronaries. They may have coronary vasospasm, although myocardial infarction is quite rare in these patients. The most common rhythm disturbance is sinus tachycardia that is usually overshadowed by atrial fibrillation. A minority of patients could present with high output heart failure due to increased resting cardiac output and enhanced contractility. The treatment should include a beta blocker to lower the heart rate. Our definitive therapy here can be accomplished by thyroidectomy or radioactive iodine. Hypothyroidism. In contrast to hyperthyroidism, hypothyroidism presents with subtle cardiovascular symptoms, mild bradycardia, diastolic hypertension, low apical impulse, an increase in serum lipids, additionally increased frequency of pericardial effusions. Echocardiography can show effusions in up to 30% of hypothyroid patients, which resolves over weeks to months after replacement. Now to the adrenal. The Cushing's syndrome has been positively correlated with increase in atherosclerosis. Hypertension in Cushing's syndrome is characterized by the loss of nocturnal dip. This non-dipping pattern has been attributed to hypercortisolemia with the loss of the bedtime nadir in serum cortisol levels. Within the general population, non-dipping is associated with an increased risk of cardiovascular events, both in hypertensive and normotensive individuals. A recent literature review suggests that administration of antihypertensives at bedtime may reduce cardiovascular risk, but notes that further targeted studies with adequate statistical power are needed. As we can see in this figure, cortisol causes hypertension through a variety of mechanisms. The bottom line here for us for the non-endocrinologist is because it has multiple pathophysiological methods, it should be treated with several drugs, and there's no one solution to fit all. The mainstay here is to normalize the cortisol level. However, there is often a long delay before definitive surgery is performed, and some patients are unable to undergo surgical resection for a variety of reasons. In these cases, antihypertensives must be started as early as possible until the surgery is done and the effects can be assessed. In one study, 28% of patients with Cushing remained hypertensive 1 year after surgical cure. Although the severity of hypertension did not predict hypertension remission, a longer duration of hypertension was associated with the lack of remission, possibly because of vascular remodeling. This provides an ancillary reason for aggressive treatment of hypertension before surgical cure. Conn's syndrome. Often the patients are asymptomatic, may present with symptoms of fatigue, muscle weakness, or cramping, secondary to potassium wasting, headaches, palpitations. They can also have polydipsia and polyuria from hypokalemia-induced nephrogenic diabetes insipidus. Many patients are discovered to have Conn's syndrome as a result of persisting hypokalemia and hypertension. Others may present with serious arrhythmia after being started on diuretics for hypertension. To lower blood pressure, spironolactone is the preferred drug, as it also normalizes the serum potassium levels and plasma volume. Non-surgical treatment is an option for patients who are frail and have numerous comorbidities. In addition, bilateral adrenal hyperplasia is also managed medically. Adrenalectomy is used to excise unilateral lesion. Prior to surgery, the patient has to be treated with spironolactone for at least 4 to 6 weeks. Today, laparoscopic adrenalectomy is widely used to excise the adrenal glands. About 2/3 of patients become normotensive after surgery, but blood pressure may take around 6 to 12 months to stabilize. Over 5 years, only about 50% of patients will remain normotensive. Those who fail to respond to spironolactone prior to surgery will most likely continue to be hypertensive after surgery. Hypogonadism. Male hypogonadism is defined as low circulating testosterone level associated with signs and symptoms of testosterone deficiency. Although the bidirectional link between hypogonadism and cardiovascular disease have been clarified, the association between testosterone and chronic heart failure is more controversial. As we can see in this figure, testosterone plays a major role in a vast majority of organ systems. The low testosterone levels are associated with cardiovascular risk and disease, major adverse cardiac events, and mortality due to cardiovascular events. Furthermore, a bidirectional link exists between low testosterone levels and metabolic disorders such as metabolic syndrome, obesity, type 2 diabetes, and cardiovascular mortality and morbidity. Longitudinal studies have shown that patients with untreated hypogonadism experience unfavorable metabolic, cardiovascular, bone, skeletal muscle, and exercise capacity outcomes in addition to sexual dysfunction. Many studies have shown that testosterone replacement therapy has beneficial effects in hypogonadal men on metabolic and cardiovascular risks, such as fat-lean mass ratio, waist circumference, glycemia, insulin resistance, lipid profile, and blood pressure. Some studies have demonstrated that thyroid replacement therapy has a protective role against cardiovascular events and mortality in older men with a testosterone deficiency who are at high risk of cardiovascular events. A recent large prospective study of more than 4,000 men with a median follow-up of 19 years showed that lower testosterone levels are associated with incident heart failure. Notably, the testosterone heart failure field is covered by guidelines from various endocrinology, andrology, and urology society, although it is poorly acknowledged in the cardiology society guidelines. Menopause. Clinically, natural menopause is defined as a one-year period of amenorrhea following the final menstrual period without any pathological or physiological cause. The median age of menopause was reported to be 51.3 years in the Massachusetts Women Health Study. Hormone replacement therapy is considered to be the most effective treatment for relieving menopausal symptoms, but potential side effects could be present. Initiation of hormonal therapy early into menopause transition may be safer with regard to cardiovascular disease, resulting to a lower absolute risk of venous thromboembolism, cardiovascular disease, and stroke in the early menopausal years. There are many other endocrine diseases which lead to cardiometabolic complications, including hypertension and heart failure, such as pheochromocytoma or paraganglioma, which cause more heart failure with reduced rather than preserved ejection fraction, severe primary hypothyroidism, which causes more heart failure with preserved ejection fraction, more than the reduced, congenital adrenal hyperplasia, the 11 beta hydroxylase deficiency and 17 alpha hydroxylase deficiency types cause both types of heart failure. The carcinoid syndrome is pure heart failure with preserved ejection fraction. The lipodystrophy syndromes cause heart failure with preserved ejection fraction more commonly. Liddle syndrome causes both types of heart failure. And that's it. Thank you.